All right. Hello, everybody. This is Bruce Robinson, and here we are for the DOPPS Spring Update meeting, take two. Of course, we tried this last week and had a major technical issue towards the start, and we do appreciate. Number one, I apologize for those who called in and for any inconvenience that caused, and we thank you so very much for calling back again this week. We anticipate a show that will be entertaining and go off without a major hitch this time. So thank you so very much for joining us. Next slide, please. And the next slide as well. All right, I just wanted to start again by acknowledging our funding supporters. DOPPS program would not be possible without the support for our independent scientific research from the organizations listed here. We thank you so very much. Next, please. And once again, I wanted to give just a very warm thanks to all of you who've supported the DOPPS program over the years through whatever contribution you may have made. And in particular, thank you to our country investigators, our medical directors, site coordinators, and the many thousands of patients who've worked with us. So we've actually, the program has been running for over 5 years, since 1996, currently active. Next slide, please. Currently active in close to 800 sites worldwide and 19 countries, with close to 35,000 patients actively involved in the study. Thank you so much again, everybody. Next slide, please. We remain very active from a research output standpoint, so very robust research program in the last couple of years, as demonstrated in this slide, with well over 1 publication per month. And I must say, I'm actually very, very pleased as well that we've given a lot of opportunities to junior investigators for first authorship and supporting roles. And it remains a very important goal of ours to assure that younger investigators have a chance to work with us and work with our data and learn and develop as in their research careers. Next, please. Okay, then moving on to the agenda for, I was just going to note, of course, we had timed this last week to be just before the start of the ERA-EDTA meeting. And from my point of view, that appeared to be a very productive virtual meeting with strong attendance and excellent lectures. And I'm still learning more from some of the output that's being sent around post ERA-EDTA. I hope others enjoyed those proceedings as well. This weekend is actually the JSDT, or Japan Society of Dialysis and Transplantation annual meeting, which is a massive conference as well. A number of folks who would typically call into us may be busy with the JSDT meeting in Osaka this week. All that said, here is the agenda for today. We have a 3-hour program. We will start with so we're going to start with a roundtable discussion related to COVID, which I'll get into in just a moment. Following that, we'll have research presentations from our DOPPS study, as well as Pdops and CKDOPS, as noted here. Next slide, please. Okay, so for participants, we'd love to have this to be as interactive a program as possible. Please use the Q&A function, which is available for you to use on the left-hand side of your screen, as noted here. Your lines as participants are muted, but please communicate through this feature. And we have folks here ready to go to help triage and answer questions, so please send them on. Next, please. All right, then moving on to the first session here. Well, it's really been an extraordinary time with COVID over the last 5 to 6 months, and really something none of us had predicted or anticipated. And of course, in particular, as providers of care for patients with advanced or end-stage kidney disease, these are folks at exceptionally high risk with numerous challenges to meet that are really, in many ways, quite unique to our population. As the DOPPS program, we've been interested in doing the best we can to to assure we can help make a difference. And one way we can do so as a group is sort of get the word out there about what's going on worldwide. And this is actually the impetus for this. We're calling it a roundtable discussion. Next slide, please. And indeed, we have 15 countries slated to present over the next hour and 15 minutes. In fact, amongst that, we'll have 10 live speakers and 5 who've given me slides, and then I'll be reading through their slides for a number of reasons. There are a couple folks who were able to make it last week and not this week, but either way, we'll be representing 15 different countries from Asia, Europe, and then the Americas. And I really ask people to think about, to perhaps give some sense for the epidemiology of the condition of COVID as it pertains to dialysis patients, but also speak quite personally to what's been going on at their dialysis unit, the struggles, challenges they faced, and ways they managed them, and perhaps even some yet more personal sort of insights with respect to this. I will note that we, the DOPPS program has also recently sent out a survey to all of our study sites and our hemodialysis sites, and soon to be our PD sites as well, to get a more quantitative sense for effect of COVID on practice. And we look forward to bringing those results together quickly and reporting out to the public quickly on those findings. I will note as well that we are in the process of developing a collaboration with the International Society of Nephrology, the ISN, to distribute that survey yet more widely. So we're actually very, very excited about that possibility. Anyway, with all that said, let's launch into the program, into our speaker set itself. Next slide, please. As a way of introduction, I pulled up the Johns Hopkins University website is just such a great resource with respect to epidemiology of COVID. And what I've done here is use stars to represent the countries that will be that are represented here by continent. So we've got 5 countries in Asia, which I've starred in green, and I'm showing here the mortality rate per 100,000 population, which I think in some ways is perhaps the best way to understand the impact of COVID in a given country. And of course, it's quite striking that our Asian countries have much lower mortality than, for example, the countries in the Americas. We have 3 countries, U.S., Canada, Brazil. Actually, the mortality rates are roughly, for example, in U.S., roughly 50 times higher than in Japan, Korea, etc. And indeed, in Europe, we have 7 countries. These are in blue, and all of those have death rates that are somewhat higher, perhaps even twice as high as the U.S. So really substantial burden from COVID in these countries. I'll say that Germany is actually an outlier there in that their mortality rates are notably lower than the other 6 European countries here. So with this by way of background, wanted to launch into our country-level speakers. And next slide, please. We're actually starting with our 5 Asian countries. And Dr. Gon, there have been some issues with audio for Dr. Gon. Dr. Gon, have you been able to get on yet? And right, I think what we'll do is skip our Chinese representative, Dr. Gon, for right now, and get back to her at the end of in about 15 minutes. And if we've not resolved the audio issue, I'll walk through her slides at that point. Okay, so next, from Japan, Dr. Tsuruya, who's a professor at Nara Medical University in beautiful Nara in the middle of Japan, next to Kyoto, is involved with collection of data through the Japanese Dialysis Registry. Now, I mentioned earlier that we have a survey that we sent out to medical directors worldwide. We didn't send it out to Japan, and the reason why is because there's almost no COVID in dialysis units in Japan. So it's really quite striking. This first slide here from Dr. Surya does show the number of cases in the population, Japanese population at 17,000, and the number of overall deaths, which is under 1,000. The U.S., the deaths are now 110,000, so on a per population basis, about 50 times higher in the U.S. than in Japan. Next slide. This slide is actually looking at dialysis patients. This is the number of cases, roughly 100 cases, and you note that that's actually flattened out in May. So some modest number of dialysis patients with COVID, but very modest number. That's indeed flattened. Again, the numbers are something like 1 in 50 or 1 in 100 compared to the U.S. And number of deaths total is 16. Now, Japan has very large dialysis population, about 350,000. So we're talking 100 out of 350,000. Next slide, please. This slide shows that the incidence rate of COVID is about twice as high in dialysis patients compared to the general population in Japan. So twice as high, but of course very low to begin with. And the next slide, the last slide from Professor Surya, shows the mortality rate, which is roughly threefold higher in dialysis patients compared to the general population, 16 versus 5 as a percent. And these numbers may resonate with other countries, right? We see generally, mortality rates that have anywhere in the overall population, probably in the range of 1 to 2%, but notably higher in dialysis patients. So these mortality rates are perhaps comparable to what we see elsewhere. It's simply that the occurrence of COVID is so much lower. And I think it's really, really interesting, and then there may be time to delve into this a bit, or I'd be interested in thoughts on this, but really what are the reasons that COVID has been so well controlled in most of our Asian countries? I mean, I think it probably does relate really to ultimately to wonderful public health infrastructure, testing, isolation, relatively wide isolation of contacts, contact tracing as well, and then adherence to those sorts of guidelines. So it seems like this solution at the public health level has been, so far at least, very, very effective in Japan. Next slide, please. Good. Okay, we're actually moving on to Korea now, and Professor Yongling Kim, who leads our peritoneal dialysis study in Korea, has just done great work with us, and he was able to speak last week, but not this week, unfortunately. But he has about 5 slides, which I can walk through here. This shows, again, this is from WHO, but confirmed cases over time, which is flat. I mean, folks on the phone know that Korea was considered an early sort of index country, but really impressively, the Koreans were able to really control the spread of COVID very effectively. And so you see confirmed cases of 11,000 in the population. And we see deaths of only 300 total. Korea, I think population 60, 70 million. So, again, it's probably death rate that's in the range of 1 in 100 compared to the U.S. per population. So really, really impressive. And you'll see also, a spike in cases on the bottom there, spike in cases early on the left, and very few new cases in recent weeks. Next slide, please. All right. How have they done it? Well, again, it'd be wonderful to hear Dr. Kim's input. And by the way, for folks, so folks are aware, we're asking our speakers today to provide a brief write-up of what they'll be presenting today with some additional context. So Dr. Kim will provide it in that format, but it'd be just wonderful to hear what he thinks has worked so well in Korea. But what he has here is a demonstration, first of all, testing widely available and available early. This is via PCR, of course. Antibody testing still remains not approved in Korea. Drive-through screening centers implemented early and widely as well. Asymptomatic or mild cases transferred to therapeutic living centers, therefore leading to no problems with acute bed shortages, but I think also really focusing on isolation of contacts or mild cases in this case. Amazingly, no border shutdown or travel restrictions. And as a result, mood is relieved, as Dr. Kim said. Can you imagine, I mean, compared to what we're doing here in the States, which is really social distancing over the course of the last 3 months. But here it appears that folks who are unaffected have not been substantially affected by this. Really impressive. Next slide, please. All right, he has a couple slides on number of dialysis patients. At the bottom, you'll see that 11 dialysis patients were confirmed to have COVID, 7 healthcare workers as well. Those are shown in the bars as well. And I think really impressively, what they did was they identified folks who were close contacts. And this is a pretty wide number of, I think, really interesting. 11 patients, but close contacts, 1,175 HD patients and 278 healthcare workers. So I think a pretty wide definition of what constitutes a close contact. Next slide, please. And this slide shows it's the 11 rows for 11 dialysis centers and what they did with their index cases in each, and the widespread testing that they implemented, and then the isolation of close contacts as well. And you'll see actually on the right-hand side number of what was considered close contacts for each case. It was in the range of, 6 up to 114 patients that were cohorted and separated. Next slide. All right, and then this shows that what happens for patients. So testing, confirmed cases received dialysis in a negative pressure room. What they call close contacts were isolated, screening test and cohort isolation. And I think this approach is somewhat more aggressive or proactive than we'll see in other countries, and did lead to really, as far as I can tell, really decreased transmission of SARS-CoV-2. Next slide. And this just shows the course for these specific patients. And next slide, please. I'm sorry. If you go back to slide 22, the slide just before. Good. Okay. This is actually a slide that Dr. Kim gave me specific to the city of Daegu, which is where he is from, metropolitan area with a population of 2.5 million, considered the epicenter of COVID in Korea. The prevalence is 3 per 1,000, death rate 2.5%. And total number of HD patients 4,000, with prevalence of 4 per 1,000, and death rate 14%. So you see the death rates among COVID identified patients are pretty comparable to elsewhere, Japan, but also elsewhere. It's just simply that the spread of COVID SARS-CoV-2 is much lower. All right, and Professor Kim says thank you for your attention. All right, and now we have the pleasure of passing the microphone on to Dr. Talungsak Kanjanabuch, whom we know colloquially as Golf, a good friend of ours. And Golf is one of the leaders of our peritoneal dialysis study in Thailand.
Okay, thanks, Bruce. Ladies and gentlemen, it's my great pleasure to share Thai experience today. Thailand was one of the first countries with a confirmed case outside China in mid-January 2020. The number of cases has been increasing sharply in March. Thus, the Thai government immediately controlled the outbreak. Public education has been promoted to control the disease in many measures, including self-monitoring, social distancing, wearing a face mask, frequent hand washing, as well as border shutdown and travel restrictions. Until now, there are 3,100 confirmed cases and 58 deaths. Okay, and next slide, please. Sorry. Dialysis patients are inevitably at high risk and need to be prevented. Therefore, recommendation for self-care of dialysis patients, caregivers, and healthcare providers has been launched in April 2020. The aim of the recommendation were to prevent patients and their caregivers from disease and to prepare themselves to be ready if there is a shortage of PD supplies. At the same time, a recommendation to PD healthcare provider has launched. It is to encourage healthcare providers, especially PD centers, to adapt their services. Unnecessary PD visits should be avoided. While teleclinic is arranged, the medication is refilled via mail. Healthcare providers are also advised to keep close contact with their patients and provide distant troubleshooting for any complication without delay via text message or video call. The recommendation also mentions self-care during a hospital visit and emphasize the management of PD waste, especially for PUI and confirmed COVID-19 cases. Furthermore, the recommendation provides protective measures for sanitation and alternative material in case of a shortage of supply using available household products. Next slide, please. As of 15 May 2020, there is one PD case and no HD patients. Unfortunately, a case with PD was dead, albeit receiving of multiple antiviral agents, include lopinavir, ritonavir, and favipiravir, and hydroxychloroquine. 13 cases with AKI received RT, including 9 CRT, 4 acute HD, and no acute PD. So in conclusion, all the measures are small pieces of nationwide preparation to deal with the dreadful emerging disease, with hope that the disease will be soon controlled and all the people are safe through this pandemic crisis. And next slide. Thank you for your attention. This is my soul of friend in Thailand Pdops for 4 years. Thank Bruce. And,
thank you so much.
Thank you.
Thank you very much. It appears to me from the first slide you showed that that the number of cases in Thailand has declined recently, which is very good news. Is that your understanding as well?
I think because of all measures that the government did, and this slide I got from the Worldometer.
Yeah, it's really great because, of course, in a number of, let's say middle-income countries, of course, there's real concern that COVID is becoming a terrible problem now. However, in Thailand, you all have done very well from a public health standpoint. That's very reassuring.
I think maybe because of good healthcare volunteer, Thailand is strong. We have almost 10,000 volunteers to take care the patient and the citizens.
I see. Volunteers were during COVID, that you've mobilized.
Right.
Fantastic.
Also go from was wondering, I mean, Thailand had a wonderful experience with PD, with growing number of patients, but also a lot of training. Have you seen the opportunity of increasing the use of PD for AKI cases, particularly in the peak of problem when especially CRRT consumables might be in shortage?
Yeah, that's a good question. You know, right now we got only 13 cases with AKI, and many doctors are afraid to use acute PD because we try in vain and encourage them to use acute PD, but they still resist because of they said, oh, the patient need to use hemoabsorption and also need intensive respirator, and they're gonna compromise diaphragm or something like that. So they try to resist and acute PD, but we will try harder to start acute PD in COVID-19 in Thailand. But right now, the active case is very low, so we will see maybe I'm across finger crossed that we don't want to have a second wave, but we don't know because nearby country like Malaysia, Indonesia, the case is still increasing. So we will see what gonna happen for Thailand.
One question from the audience, actually, Dr. Karkar, a good friend of ours from Saudi Arabia. What is the role of volunteers? Oh,
volunteers are trying to educate, empower, and keep the citizens to social distancing, and educate them to wear face masks, hand washing, and every measure. Because you know, in my country, it's a low middle income country, but 80% of the citizens is poor. So we need they have a low educational level. So the volunteer need to educate them, try to keep them in their house, not try to keep social distancing, something like that.
Yeah, indeed, fantastic. So social support really is very, very strong, which is wonderful. Next slide, please. Golf, thank you again so much.
Thank you both.
Oops. There we go. Okay. Yeah, Mohammed Al-Ghanaim, who's a country investigator with us from the Kingdom of Saudi Arabia. And Mohammed, thank you so very much for speaking today.
Thanks, Bruce. I would like by starting with thanking the DOPPS team for giving us this opportunity to present the local data. So I would start with, so the first reported case of COVID-19 was reported on the 2nd of March, 2020. So, and then since then, the number of cases were increasing. Last week, the number reaching up to 93,000. Today, it was up to 100,016. The mortality is 857 cases so far. The fatality rate is around 0.7% of the total, and you have mentioned that per 100,000 population is 1.7. The recovery rate is good, 74%. However, we are still having an increasing number of cases, which is as a result of community transmission. The critical care cases were up to 1,321. Daily, we're having around between 2,500 and 3,500 cases daily. Next slide, please. So I just wanted to give you a general idea about the dialysis and how does it look like in Saudi. So currently we are having over 278 dialysis centers, and as you can see, the number of dialysis centers has increased over the last 30 years or so. Majority of the dialysis patients, or the etiology or cause of end-stage renal disease, is combination of diabetes and hypertension. We have other causes like GN and others, but over 50 to 60% of the cases were diabetes and hypertension. The dialysis population are younger compared to the DOPPS countries, and we compared this in more than one study. So with the average age between 40 and 45 years. Next slide, please. Till last week, we have the number of COVID-19 infected dialysis patients, hemodialysis patients, were up to 90, and one peritoneal dialysis patient. The death is 5 patients died because of the infection, and the number of COVID-19 infected healthcare workers are 34. Next slide, please. So I will go through the questions sent earlier by Bruce. What is the mood now among patients and staff? We'll start with the healthcare worker. With the nurses, initially they were scared, anxious, and some of them were trying to find an excuse to stay away from exposing themselves to a positive patient or a high-risk patient, and some of them demand an immediate testing once exposed to a suspected patient or infected patient, which is obviously known. However, after dealing with the first few cases and applying all the PPE measures for all healthcare staff, as well as masks and screening for the patients entering the dialysis unit, they were reassured and they were relieved after that. Regarding the physicians as well, initially they were scared and anxious as well at the same time. However, can you go back to the slide, please? Yes. After dealing with the first few cases, confirmed cases, they were much relieved, and they were using the PPEs early on, and the test was, and if they have exposure, the test was performed shortly. In terms of patients, so they were worried initially and stressed and not happy about the change of process, because the process has changed when they presented themselves to the dialysis center. Initially, they have to be triaged by the nurses. They have to put on their masks. They have to go through screening and few surveys, questions, and their watcher or their companion, they were not allowed to go into the dialysis unit. And they have to wait probably few minutes to 30, 45 minutes before getting them into the machine. So they were stressed out because of this. The other thing which I think makes them stressed out as well, they were trying to hide, some of them, they were trying to hide their symptoms. Some of them, they were trying to take paracetamol in order not to have, when they measured, they not to have fever. However, after putting them on dialysis machine, they start to show their fever and other symptoms. And I think they were doing that initially because they were trying they were afraid that it might influence their treatment and dialysis schedule if they have symptoms suggested or suspected of having COVID. And some of them, they were afraid that they will be transferred to another facility or hospital-based hemodialysis center, and as well the impact on their family members is an important. Next, please. What are the changes in the hemo center? Actually, we have learned from MERS-CoV in the past. So the visual triage, most of the dialysis center visual triage is done by 2 staff, 1 nurse and 1 physician. Active surveillance for symptom, and then home triage as well. Some of the dialysis center, they were calling the patient twice weekly to make sure that they don't have any symptoms suggestive of COVID. And they were doing that by phone calls. Face mask for all patients and hand washing before going into the dialysis unit. And no more waiting area, so it was cancelled, and no watcher is allowed to go in dialysis unit. So the impact of this were longer waiting time before entering the unit, and some of the patient has their dialysis session were changed. Regarding the staff, it's a universal PPE use with the head cover, gloves, face mask, and the shield, face shield as well. And the impact on that as well is more shift, because they would have to change some of the dialysis centers scheduling and to shift the patient and to open a new third shift or so. And some of the quarantine for the contact, i.e. the staff, had an impact on the rescheduling of their workload. Next, please. How were we dealing with the hemodialysis patient confirmed with COVID-19? Asymptomatic one were isolated and dialyzed in the same facility with all the precautions. However, the symptomatic one were transferred to a hospital-based hemodialysis center, and some of them were assessed for admission. Some of them were admitted to the hospital for further evaluation and management. And there's an ongoing project now to have a dedicated unit for COVID hemodialysis patient in certain areas in which we have more and more cases. Next, please. Yeah. So there was one, I think, important question. Will home hemodialysis be an option more common? I don't think in Saudi it's more common, and the patient were not asking for it. So the answer was no. And once again, thank you very much, and I'll be more than happy to entertain any question or comment.
Mohammed, thank you so very much. And indeed, this will be real interesting to see how things go, as unfortunately the number of cases does appear to be rising, or has risen recently in Saudi Arabia, and so it will be very interesting to see how that goes.
Yeah, I want to comment regarding that, because the lockdown is loosening some of the measures, such as curfew. Is less time now for the curfew, and lockdown is not anymore, and allowing malls to go back. People can go back to the malls and restaurants and others. So I think that contributed majorly to the increasing number of patients. Currently as well, the government is doing wide screening with, they're trying, the plan is to screen actually over 10 million population or so. So I think the number will increase because of that. So we're capturing more and more of asymptomatic patients.
Oh, good. Indeed. Okay. So that's actually quite positive. I think in the interest of time, we'll move on to the next speaker. Actually, Professor Gan from Beijing, I believe we have gotten audio from you, and is that correct?
Hi, everyone.
Hi.
I'll show you. Hi. Okay, I'll show you our story in our center. In mid-February, one inpatient of our hospital was diagnosed with COVID-19 after symptoms onset for 18 days. She received regular hemodialysis at our dialysis center. So this patient caused many people in our center being exposed more than once. The patient was transferred to a designated hospital on the same day she was diagnosed. All the close contacts were isolated for 14 days, and none of them got COVID-19 infection. I think that's not only because of lucky, but also because of the strict preventive and control strategies. In mid-January, immediately after the first case of COVID-19 outside Wuhan was reported, our center began to implement strict measures. All patients and companions should wear surgical face masks throughout the waiting area and during dialysis treatment. Also, we provided patients with instructions about hand hygiene and healthy cough etiquette. If a companion was needed, the companion should be a constant one and was not allowed to enter the dialysis hall during treatment. So all patients should keep a safe distance of more than 2 meters with other people. After this patient being diagnosed during this pandemic, we further strengthened our measures. We prepared emergency plans to cope with various conditions, such as the shift adjustment pre-plan while COVID-19 is diagnosed. We provided training to healthcare team, patients, and their companions. To decrease exposure, we fixed dialysis shifts to contain possible COVID-19 cases in narrow range. We asked all patients and their companions to self-isolate at home, avoid public transportation as much as possible, and avoid non-natural contact with other people. All medical staff and patients were asked to monitor daily health state. All patients would be asked whether they have epidemiological history or suspicious symptoms before they enter dialysis hall. Body temperature should also would be taken every time before they enter in the hall. And dialysis shifts would be adjusted, and further measures would be implemented according to their clinical symptoms and epidemiological history. In our center, also we do the terminal disinfection after each dialysis shift. So among all these measures, I think putting on surgical masks and hand hygiene are the very important ones. So this is our story. I hope it's helpful to other ATU centers during this pandemic. Thank you.
Thank you so much, Professor Gan. It is really impressive. So DOPPS is in three metropolitan areas: Beijing, Shanghai, Guangzhou. And to date, our understanding is that there have been very, very few COVID cases in dialysis units in those metropolitan regions. And I think all have implemented procedures, just as you have noted. So really remarkable. And I do think there is much to learn from what you've done. So thank you. Oh, thank you so much. If we, in the interest of time, we are answering some questions through the Q&A feature that the audience members can read. And if right now we'll move on to the European segment. We actually have 7 countries in Europe. And unfortunately, and here is noted already, the mortality, the burden of COVID is very, very high in Europe. And as shown here once again here on this graphic. With that in mind, why don't we launch into the first of our countries, which is Belgium. Professor Michel Jadoul, a country investigator with the DOPPS, will speak. Thank you, Michel.
Yeah. Thank you, Bruce. I'll be very brief, but I want, if we move to the next slide, where you can see the put into context the Belgian situation. So as you can see on the slide, the very first cases in early March most likely originated from northern Italy, which is one of my favorite countries. That's not a criticism for 2 reasons. There are close historical links between some cities in Belgium and Italy, number 1. And number 2, there are no mountains in Belgium, so a number of Belgian people went to Italy to do skiing in the winter and came back with COVID. So there was the outbreak in March and April. You have on the top side the number of cases per day. Belgium is small, remember, and the cumulative case. So as you can see, March and April, the lockdown was started in Belgium in March 18, if I'm right. Next slide. Now this is the general population, of course. The next slide shows you for the French-speaking registry. So let's say 40% of the dialysis patients. I owe the slide to Frédéric Collard from the registry. On the fourth column, that there were something like 250 or 300 dialysis COVID-19 cases on the French-speaking side out of something like 2,200 dialysis patients. So it's quite significant. It's all except negligible. The next slide will show you unit by unit. And if you look in the middle, so it's not anonymized. I thought it would be, but okay, that's not a problem. Please do not distribute this. And if you distribute the slide, it should be sent out without the names of the hospital. I thought it would be hidden, but anyway, it's not a secret. As you can see in the columns on the right-hand side, you have the number of deaths. So many centers and one or more than one death. But more importantly, a few centers, for instance, the first row, there were 185, the first line, 185 patients in that unit, and 35 got infected. Now, previous slide, please. Meaning there has been in that unit an outbreak, definitely. Previous slide, please. Yes. Another one on the 8th one, Hôpital Ambroise Paré in Mons, again, 64 dialysis patients, 33 got infected, so again an outbreak. In many other units, there was no outbreak, but a few cases. Next slide, and I will finish with a few comments from my own experience. So we heard about the very first cases in Belgium in early March, and we understood there would be a problem because a dialysis unit in Mons already started an outbreak. So we started a preventative strategy in line with what was mentioned by our colleague from Saudi Arabia. So at the entrance of the dialysis unit, there was an experienced nurse interviewing all patients about fever, cough, dyspnea, sore throat, diarrhea, and so on. If there was any suspicion, a swab was done for COVID immediately, and the patient, and of course the staff had a mask, and the patient was dialyzed in isolation awaiting the PCR result. Now we strongly discourage group transportation of all hemodialysis patients, and a week later, because there were additional cases, a few in our units, and we heard about additional cases in Belgium, we decided that all patients and staff should have masks. Now I should mention that by that time, by mid-March, there was a problem with the supply of masks in Belgium and in several European countries, to the best of my knowledge, especially the FFP2. We dialyzed all COVID-positive patients in a separate room. We had a maximum of 8 patients at the same time. And we were fortunate to have a system used for patients with multi-resistant bacteria. So the room is disinfected by vaporization of a gas, in that case H2O2, meaning that there is gas in the atmosphere and it really disinfects the whole environment, and the room can again be used the next day for negative patients and so on. And my last slide. In early April, we eventually, because in March that was difficult, my university hospital did in the lab the screening for the patient, but screening everybody was not possible because of the limitations in terms of reactives to do testing. Early April, we had the opportunity to screen all the hemodialysis patients, and we had already at that time 8 patients already positive. Screening detected 2 more, which were virtually asymptomatic and isolated. We had a total of 2 deaths, both with severe disease, major comorbidities as shown on the slide, and the other 8 patients recovered relatively easily, I would say. We have no strong evidence, but we have as yet no analysis of the viral strains. We have no strong evidence if we look at the map for patient-to-patient transmission. But that's anecdotal at this stage. We had, in contrast, several nurses. I suspect some of them were contaminated by their family at home, but I suspect also, as yet I cannot demonstrate, that some were contaminated despite the protective equipment, maybe not used optimally within the dialysis unit. Fortunately, all of them recovered. And we have looked very recently at the anti-COVID antibodies levels, and we have preliminary results showing that all the 8 patients who survived, not the 2 who died, we have a too short follow-up to be able to say something meaningful, but all those 8 who survived developed antibodies against both IgG and IgM within 3 weeks after the first positive PCR. That does not mean that I can answer the question whether the titers are similar for the dialysis patient versus staff and so on. That may come later. Thank you. Any question, welcome.
Michel, thank you so very much. And again, questions encouraged through the Q&A function. We'll move forward in the interest of time. And again, questions and discussion can occur on the side. So our colleague Pablo Urena, who is a DOPPS country investigator from France and works up in the northern suburb of Paris. Pablo. Pablo, are you with us? So I think what we'll do is, why don't we skip France for right now and hopefully get back to it shortly. We can move on to the next country, which should be Germany. Okay, good. Professor Cleophas, DOPPS country investigators, actually prepared one slide, and I asked, which I'll walk through very, very quickly. As noted, the mortality rate or generally burden in Germany is lower overall than in other European countries. Professor Cleophas noted several things of interest. Number one, special situation of dialysis patients living in nursing homes. This is a major source of infection in our centers, so this is an area for discussion and consideration. Number two, transportation to dialysis centers has been a problem. Before COVID-19, that was provided in group transport, but this has been changed to single-person transportation. Michelle in Belgium alluded to the same issue. So likely good for helping prevent transmission, but all sorts of logistical problems as a result of this. And then Werner also noted what's going on with respect to dosage of heparin during dialysis treatment, and what do we really know about that? And I think in this case, Werner's referring to not folks who are acutely ill, with ICU dialysis, but, for example, COVID-positive patients managed in the outpatient dialysis unit. It'd be interesting to hear any input from folks on the line through the Q&A function with respect to any of these particular comments that Werner raised for us. Thank you. Next slide, please. All right. Paolo from University of Perugia, are you available to speak on behalf of the Italian experience? So Paolo, we had been having some issues with audio connection for Paolo as well. Those may not have been resolved, it appears. And okay, so I'll walk through Paolo's slides very quickly. Okay, Italian Society of Nephrology did send out a COVID survey. Next slide, please. And here's details about the survey, which actually includes HD, PD, as well as transplant patients. Next slide, please. And indeed, this shows the distribution of COVID per 100,000 RRT patients. And as folks will know, of course, northern Italy, the Lombardy region, Milano area, and Torino areas in particular, very severely hurt. And as Michelle alluded to, also perhaps a source of some outbreaks in Belgium as well. But anyway, you do see a substantial burden in the north of Italy. Next slide, please. This shows the same data, but broken down by HD on the right, PD, and then HD on the left, PD and transplant on the right. And the numbers may be difficult for you to see, but the infection rates in HD are highest. PD sort of somewhat lower, and transplant lower still, but still I think perhaps slightly elevated over the general population, even in the transplant population. It looks like actually it looks like in the range of 2 to 3 in northern Italy, 2 to 3 out of 100 transplant patients infected with COVID. Next slide, please. And this is actually looking at mortality rates or case fatality rate among HD patients. And here among folks infected, the mortality is pretty comparable across the country. Some of the numbers are really quite high. This is per 100 HD patients. And it's interesting, it would be interesting to get Paolo's perspective on this when we are able to But you see in some of the regions, actually, case fatality rates are in the range of 30, 40 per 100, or perhaps even higher. Next slide, please. And indeed, that was all from Paolo. Why don't we move on to Alex, Cases, who's in Barcelona. Thank you.
Yes, Bruce, thank you for the invitation to share the Spanish experience. Next slide, please. Yes. As you can see, Spanish is one of the European countries initially hit most by the COVID-19 pandemic, but the distribution of the infection between regions was heterogeneous. And in fact, the Spanish Society of Nephrology has created a registry of cases, and we had right now the new figures are 1,700 patients on renal replacement therapy in Spain that were infected and reported to the registry. All the autonomous communities reported cases, but especially the community of Madrid, which was the one in which the prevalence, the incidence of the pandemic was higher, followed by Catalonia, which also was also hit by the pandemic, Castilla-La Mancha and Castilla y León, which are in the center, close to the Madrid region, which was the origin of the most of the pandemic that we had in Spain. Taking into account the number of patients on renal replacement therapy in Spain, according to data from the Spanish Registry of Patients of 2018, up to 2.7% of the total of patients have been infected and reported by COVID-19. And the percentage range from 7.4 in Madrid to 0.1 in Murcia, which is one of the regions which had the last episodes of the pandemic. The evolution in the number of cases that you can see in the graph in the upper part of the pandemic, you can see there's an increase, especially at the beginning, and later on there's a decrease, which is close to what happened to the general population in Spain. So it reaches a peak in early April and decreasing since then. The mean age of the population was 67 years, and almost two-thirds of the cases were male. By modality, hemodialysis in hospital and satellite units was 64%, followed by kidney transplant 32.6%, and less frequently PD by 2.9%. And of course, there's a huge overrepresentation, as you can see in the graph on the left part, in the lower part of the graph, you can see that there's overrepresentation because in Spain most of the patients are kidney transplant, more than 50% of the patients, while the patients that had the COVID-19 was 64%. So there was overrepresentation of hemodialysis. The situation was nearly half of the patients were dialysis in center, in hospitals, and the other half in outpatient units. Considering mortality, the mortality in hemo patients was 27.2%, which practically doubled that of PD patients, which was 14.6%. The incidence and prevalence in hemodialysis patients varied between units. There has been some outbreaks in some of these dialysis units, but not too much. I don't have the exact figures. And dialysis patient living in nursing home was a special risk of infection, as I think it has mentioned before. We implemented face masks and hand washing in the units, and before entering the patients there was an interview and the temperature was taken. COVID positive patients were referred to the hospital, and the PCR was negative, which was usually take longer than in the general population to be negative than expected. There was also infections among the healthcare professional, especially at the beginning because of the lack of protocols and a shortage of PPEs. And in fact, more than 51,000 healthcare workers have been infected, and unfortunately, 2 nephrologists have died during the pandemic. the hospitals were upside down in order to adapt to the new situation, particularly to create COVID-19 areas, dialysis for COVID-19 patients, and to expand intensive care unit beds, and now things are progressively normalizing. We have had also, especially at the beginning, a problem with the availability of PCRs for the pandemic, so we cannot do general screening among the dialysis units at the beginning, which was when the situation was worse. But now I think that the things are getting better. Hello?
Yeah, indeed. Yeah, thank you so much, Alex. All right, yeah, we'll move forward in the interest of. Oh, there was a question from Anna Marti, Alex. Any infection for home hemodialysis?
I think very few people with home hemodialysis. I don't have the figures, but someone, yes, but of course, but because of contamination from families or friends, that's the same that happens with PD. In fact, we have had a very low numbers among PD patients because also they are dialyzed at home. So type 2.9% with in the PD patients in Spain is around 10%. So in fact, there was overrepresentation among the hemo units where the patients share, so the contamination is much easier.
Yeah, indeed, I would agree. Probably generally comparable to PD. Okay.
Yes, exactly. No, I know there have been some, but the numbers are really small. In fact, because the numbers of home hemo in Spain are low, but despite that, of course, the numbers that have been reported are really, really low.
Indeed, right. Yeah, thank you. Thank you so very much. Okay, next slide is actually for Sweden, and Stefan Jakobsson from Karolinska gave me a single slide. As we know, there has been high burden of COVID in Sweden, and somewhat different approach on the public health from the public health perspective, particularly for lower risk individuals. I won't take time to read through all of this, but I will note actually in the middle, interesting point from Stefan, maintenance dialysis patients. He noted that many old and frail patients have PCR positive infection, but actually do very, very well. He thought more than, in his sense, more than 50% actually did very well with this. So, there were, of course, a substantial proportion who got very sick, and as well as mortality, which is moderately high, at 20%. But again, a good number of folks actually did quite well. So I think it will be so interesting as we start to develop widespread availability of antibody testing, particularly in our dialysis patients, to really get a sense for how widespread infection has been. Stefan also notes that the use of telemedicine worked very well and quite likely will lead to further changes in provision of health care in his country. He was also struck by the fact, as others have noted, that decreased presentation of folks to emergency departments for other conditions. What's actually happened to those folks who, in terms of MIs or presentations with stroke, etc. Okay, well, thank you, Stefan. Next slide. So our colleague Indy Dasgupta, who's an investigator with the DOPPS from Birmingham. Indy.
Thanks, Bruce. Thanks for asking me to do this presentation. I will try to be brief. Now, as we all know, that UK has been quite badly hit with, and as you've shown quite earlier from the Johns Hopkins COVID dashboard, that UK has had the highest mortality per population. So the death toll is 41,000 at present, which is only second to US. This is total deaths, and are likely to be very soon overtaken by Brazil at the current rate. But like in other European countries, kidney patients have been disproportionately affected by COVID-19. And there's just a snapshot from the UK Renal Registry data. Now, I've chosen 20th May as the point of report. mainly because that's just past the peak in the UK, but I can give you the figures from currently as of today. So as of just past the peak in the UK of COVID-19 infection, there were 4,000 patients, of which patients with renal replacement therapy and some CKD as well in it, of which about 1,200 deaths, which takes the case fatality rate to 30%, which is much higher than in the general population, so about 3 times or more higher than that. Currently this has gone up. So the total number of deaths in UK kidney patients is around 1,400, and the case fatality has gone up to 32%. So that's kind of the ballpark figure, 32%. I haven't mentioned other, as you noted, I said England rather than UK, because the other nations in the UK were less affected, relatively less affected than England. Next slide, please. Now, this is from my own hospital, and it is just to show that similar, even locally, we've seen similar case fatality of 32% among kidney patients. And to note that it's the hemodialysis patients and the CKD patients that are mostly affected. Now, of the hemodialysis patients, they're mostly in-center dialysis patients, dialysis patients in the hospitals and in satellite dialysis units. And in response to an earlier question, I was just looking at the registry data. Actually, it's the lab confirmed cases among in-center hemodialysis is 10.6% in the UK, while among the home dialysis, home both PD and home hemodialysis is about 2.7%, so much lower. And similarly, transplants patients at 1.2%. So that's kind of what our experience locally has been as well. So it's the hemodialysis and non-dialysis CKD population that have been mainly affected by COVID pandemic in the UK. Next slide, please. Now, what do we do? This is not much different from what other countries have done. So we have kind of reorganized our dialysis, hemodialysis, as it's mainly talking about in-center hemodialysis. So we divided our dialysis centers, the center dialysis and satellite dialysis units, into hot and cold sites. The hot sites are where the COVID positive patients and the suspected patients dialyzed. Cold sites where patients that are not suspected or of having suspected of having COVID were dialyzed. And like we heard from Spain and Italy, so use of personal transport was encouraged where possible. Patients were asked to wait in the car rather than in the waiting area to reduce mixing. And patients were asked to use surgical mask while they're on dialysis, and the staff used PPE, including visor or face shield. Some of the patients were selected to have twice-a-week dialysis. Now, of course, taking into consideration the issues around fluid overload, hyperkalemia, and in some instances, patient preference is to reduce exposure rather than reduce workload. So roughly around UK in most centers, is around 20% of patients were changed from temporarily from 3 times a week dialysis to twice a week dialysis. We generally in the UK, all dialysis facilities have a monthly QA meeting, and those were changed to virtual meetings. Sorry, I've lost my slides. Can I have my slides back, please? Next. And there's a very high staff sickness. At peak, about 30% of dialysis unit nurses or staff were off sick. So we had to redeploy staff from other areas, including research nurses. In fact, all my 4 research nurses, of the 3 were deployed to the dialysis unit to help with dialysis. And I know in some centers in the UK, the nephrologists had to go and help put patients on dialysis. Next slide, please. We also saw a very high number of AKI in ICU. So roughly 1/3 of patients with COVID-19 that were receiving ventilation in ICU developed acute kidney injury. And these patients have very high mortality, as you'd see here, 80% in hospital mortality in these patients compared to AKI ICU patients. And as a result, there's a high demand for CVVH, and by the 3rd week of April, there was a national shortage of CVVH fluid and consumables. And so we had to support the ICU with intermittent hemodialysis, and that again put strain on the hemodialysis service. And some centers in the UK, especially in London, use acute PD to deal with the situation. Next slide, please. The other issues is most of the clinic activity was done virtually. Apart from the urgent cases, most patients were reviewed virtually through telephone mostly or video. Clinical research in the UK non-COVID studies have been paused from the middle of March, and there's no indication when they'll start, although I hear in some parts of the country non-COVID research is slowly starting. That includes DOPPS. Kidney transplantation has been on hold in most centers since 3rd week of March. And again, there were only few centers that carried on doing kidney transplantation, and I hear their outcomes were not great. Next slide, please. So what have we learned from COVID-19? This is absolutely my personal opinion. A number of new models of care have emerged, and some of those I think will stay. For example, virtual CKD clinics and other clinics. Perhaps more use of intermittent hemodialysis and acute PD and intensive care unit. Restructuring of dialysis services. We should probably be considering more home-based therapy, as we've seen that home-based patients have much less infection and much lower mortality, and this is mainly because they're able to isolate, they're able to shield effectively. Early transplant is something I think we, as a result of this, we should be considering more, and the recently introduced opt-out organ donation law in England will, I'm sure, help in this regard. And the other thing that I think, the one thing that we probably didn't do very well, early shielding of cases of kidney patients, that there was a bit of a delay in shielding, and that I think will probably one of the learnings from lessons from this epidemic. And then web-based meetings, educational platforms, conferences, I think these are going to be the norm in the future, generally speaking. There are two other things that remarkable things that I cannot help mentioning. One is development of rapid clinical guidelines. So our NICE, the National Institute of Care Excellence, produced 48 guidelines over a period of 2 months, and this is dealing with management of various aspects of COVID-19 patients, not necessarily renal. There are quite a few renal guidelines. So the Renal Association produced 17 guidelines over this period, and this is, all these guidelines were produced by busy clinicians, and so it is possible to develop guidelines over a short period of time. And similarly, rapid development and setting up of clinical trials. There in the UK, there are at least 12 large multicenter clinical trials that took shape. That from conception of the idea to recruitment of the first patient took virtually a couple of weeks to 3 weeks. And one of the studies trials have already recruited 10,000 patients. This is within the last 2 months or so. So that I thought was remarkable. And a few things that have emerged in terms of research from this experience is that we can consent patients differently. We can do virtual visits more often, and so it's a different model of delivery for research, clinical research, that I think will emerge from this. I'll stop here. You can ignore the next 2 slides. Thank you.
Yeah, Indy, really, again, the burden of COVID has been massive in the UK, as in many other places. At the same time, the innovation that's occurred as a result, and as you've alluded to, is really impressive. So there is some good that has come from this. And, for example, even those very rapid guidelines emanating from the NICE organization, really, really impressive. So Pablo, our investigator from Paris, is on but unable to use audio, and so I think we'll skip the French presentation in the interest of time. These slides will be available after meeting. We've had a number of interesting questions relating to transmission of COVID, role of nursing homes, etc. And we will reply to those using the Q&A function as we push forward. That said, let's move on. Next slide, please. So actually, you'll see that we're a bit behind on with respect to, but this is absolutely fine. I think if we finish COVID session by the bottom of the hour, by 1/2 or so, that'll be just fine. To give folks a chance to speak. Now we're moving on to the Americas. We have 3 countries: the U.S., 2 speakers from the U.S., Canada, and then Brazil as well. Okay, on to Brazil for Dr. Paquafijo.
Thanks, Bruce. And as you all know from the news and what was just mentioned by Indy, Brazil is one of the new hotspots, and which really worries the population in the country, but also the medical and nephrology community. Those are the numbers from yesterday. About 740,000 cases in the general population, and it is the 3rd number of deaths. And as Indy said, with the current rates, we will pass the numbers in the UK, becoming the 2nd biggest country in terms of number of deaths very soon. COVID-19 has affected mainly the major cities in the southeast, Rio and Sao Paulo, but also, very sadly, has hit very hard the north and northeastern regions, which are the more underprivileged cities in the country, including cities in the Amazon region, threatening indigenous populations very hard to. The description we have in terms of ICU cases that require renal replacement therapies and ICU is pretty concerning, and it is estimated that a bit higher, 30% of the ICU cases are requiring dialysis currently. The AKI system, interestingly, in Brazil is not that overwhelmed yet. And maybe this is because of the lower use of continuous therapies in the ICU in the country, and the higher use of intermittent HD and also acute PD that probably overwhelmed the system to a lesser extent than what was seen in the developed world. CKD and PD clinics are happening through virtual clinics, and there is an increased number of dialysis patients infected. There is an initiative from the Brazilian Society of Nephrology to capture those numbers, but they are not yet publicly available. Also, very sadly, there is a projected 50% reduction in the number of kidney transplants. So the numbers for Brazil at the end of the year will probably go to a number that is about 3,000, which could appear very high to some of you, but for a country doing 6,000 transplants a year, this represents a 50% reduction, which is also shows how hard the country and nephrology has been impacted by COVID-19. Thanks, Bruce.
Yeah, Roberto, thank you very much. And of course, this is a story that's still early in its telling. So thank you again. Next slide, please. All right. Actually, Jeff Pearl is the lead investigator for Pdops and really contributes a ton to our work. Also, very much involved with efforts through the American Society of Nephrology, et cetera. Jeff was planning to talk last week, this week not able to make it. In the interest of time, if we could move to the next slide. Actually, I think it's 3 slides from now. Not this one, but next. And there we go, yes. So PD and COVID-19. These are some slides that Jeff provided related to one of his ASN's talks. Some points that Jeff has made regarding peritoneal dialysis. Number one, the virus has been demonstrated in the effluent of COVID-positive patients, making, of course, challenges with respect to consideration of handling such fluid. He has also noted challenges with solution delivery. And I think in particular what's happened is that PD patients have had some discomfort with some of the outside providers bringing fluid into the home directly, and therefore challenges with respect to staffing of the delivery of solution. In fact, in some cases, delivery directly from clinic staff. Jeff also mentions the question of use of PD for observation among PD patients specifically. And then, of course, he notes the marked increase in use of virtual care and remote telemonitoring, which very likely will be extended well beyond the passing of the COVID pandemic. If we move on now to the U.S., so our final 2 speakers are from the U.S., and the first of these is Rachel, a good friend of ours, who's a professor of nephrology here at the University of Michigan. And the overall mortality, just note, the overall mortality rate is a bit lower in the U.S. than some of the European countries. That said, there are major hotspots where mortality is very high. And Southeast Michigan, where we live, is one of those. And New York, where our next speaker is from, is, of course, one as well. Also in the U.S., there are tremendous problems with disparities. So, for example, racial and ethnic minorities markedly affected with very high mortality. So, so major issues for us here in the States. Rachel?
Good morning. Thank you so much for having me here today. This has been really interesting. I'm in Ann Arbor, Michigan, which is a university town. I'm going to talk about our local experience, but we're quite close to Detroit, about 45 minutes away, and the Detroit area, which has been largely underprivileged for decades, city has been hit incredibly hard by COVID, with about 2,900 deaths, which has really driven Michigan to be number 6 in death rate in the U.S. So we've been very close to this tremendous hotspot. Our community has been impacted by COVID, of course, locally also, but part of what has driven the very high admission rate at our university hospital is accepting transfer patients from other parts of the state. And so as this peaked in Michigan in the middle of April, we had about 240 COVID positive patients in our hospital. And many of those transferred to the University of Michigan, both because their more local hospitals were overwhelmed and didn't have beds for them, and also for advanced ICU care that we were able to provide. The other interesting thing about our inpatient experience was that our inpatient chronic dialysis census was down dramatically. And so typically we'll have roughly 25 or 30 chronic dialysis patients who just happen to be in the hospital for another problem at any given moment. And that was down by at least 50% throughout the pandemic. In terms of our outpatient dialysis experience locally, there was a lot of fear that dialysis patients would get exposed to COVID through the healthcare system. And as everybody's noted, for the intensive dialysis patients, that's 3 times weekly, and exposure to other patients, transportation, staff. We were very worried that it could spread rapidly through our dialysis unit. And we didn't have, until very recently, a mechanism to screen patients or even test people who were symptomatic. And so that led to a lot of extra anxiety about who needed to be isolated. Of course, we followed precautions, including masks, as others have discussed. Our system has 3 dialysis units, and we designated one of them as a COVID positive unit. And we ended up dialyzing a 3rd shift COVID positive, and we're prepared to expand beyond that, but happily didn't need to. And we are definitely in this region in a decline phase, which will hopefully be sustained. It's hard to know whether COVID will lead to a real increased interest in home therapy, but throughout this, we've been doing education, especially for PD, both remotely and in person, and have continued training patients in person for PD throughout. One other thing that I found interesting was that for our dialysis patients, people who aren't always rule followers or strictly compliant with the markers of weight gain and nutrition and phosphorus, they really reported excellent adherence to social distancing and trying to protect themselves during COVID. I definitely felt that this was very scary to many of our patients, and I had several patients express to me that they were completely certain that if they got COVID, they would die from it, and they were doing everything possible to distance and protect themselves. And as many dialysis patients in our area have limited financial means, some of them can barely cook, they have a lot of social strain, and we don't really know the impact of this on them long term yet, but I have definitely seen this be a really tough time for our dialysis patients. Thanks very much. I just wanted to talk about what was really going on locally here. And that's it. You can move on, Bruce.
Yeah. Rachel, thank you so very much. Next slide, please. Our final speaker, Dr. Besh Srivatana. Besh, thank you so much.
Can you hear me?
Yes, indeed.
Hello?
Yes, we can hear you.
Great. Thank you again for inviting me. I'm very happy to be a part of this. I apologize, my slide's very light. Once I was trying to focus on home dialysis and some of those modifications, but now that I saw what was being talked about, I have a few adjusted comments. Just as a bit of background, my name is Dr. Besh Srivatana. I'm the Director of PD at the Rogosin Institute in New York City. The Rogosin Institute is a nonprofit dialysis provider with about 1,300 dialysis patients across multiple units in New York City, including in Brooklyn and Queens, where there is extremely high COVID rates. Additionally, our organization is very aggressive about home dialysis, with about 15% total of our population and 30% in my unit of home dialysis, 150 total PD patients, 70 home hemo. As Dr. Jeff Pearl's slide noted, we went through it quickly, but we have 240 confirmed cases of COVID and counting. But the remarkable thing is 14 were home dialysis patients. So the vast majority are in-center hemo. The caveat here is that many of these cases, since we've started counting, were since the early March time frame, and I'm certain that there's also an undercount because of availability of testing, and additionally, This was started all before we knew about social distancing and masks, and to be honest, since many of the COVID modifications were deployed. So we are internally looking at the rate of COVID infection in our units before and after the distancing measures, which we hope to get out there soon. Shifting gears a little bit, I wanted to discuss the COVID modification in our home dialysis units. The primary change is that we have moved to near 100% telemedicine telehealth for established patients, and we have maximized all existing regulatory CMS waivers to be able to provide care. The management of our home units and staff really needed to be adjusted as the situation evolved. In the beginning of March, we changed our policies and really tried to minimize in-person, face-to-face visits to those of absolute importance, and training, acute visits, things of that nature, and we really had to give serious consideration to every person and every visit in person. Additionally, we started to use telemedicine in novel ways. We conducted home visits in preparation for going home with telemedicine, and we just really needed to rethink what's truly needed in person. We also implemented a COVID monitoring protocol for persons under investigation, as well as confirmed cases in the home dialysis section, where the nurses could use telemedicine to check on them every day, and if there was a need to triage or discuss with the doctor, they were able to use the telemedicine platform to immediately call the covering doctor to get their input and see the patient, to triage them to the emergency room or continue isolation at home. Briefly, also I wanted to speak about the inpatient experience. So during the peak of the COVID crisis, we nearly tripled our usual AKI renal replacement therapy need. Probably on average, we have about 20 to 25 patients in the hospital needing dialysis, and during the peak there was, again, severe shortage of CRT supplies. Intermittent HD protocols and nursing were also changed because the nurses themselves had to, it took much longer to do a hemo treatment in terms of cleaning the machines, donning PPE shortages. All of these issues made hemo as limited as well. And so in my hospital, we did utilize acute PD, and it eventually accounted for about 20% of all renal replacement therapy at the peak. And I'm very proud to say that maximally utilizing PD, CRT, and HD allowed us to provide RRT for every AKI COVID patient who needed it. There's been some other questions and interest about this. So again, I've spoken to my colleagues around New York City, among the top centers with the highest volume, and I know for a fact that there's been at least 100 patients treated with acute PD in New York City. And in my opinion, and I can't reinforce this enough, that having a protocol and plan in place to deploy acute PD if you need it is critical. In the event that your system's overwhelmed, you do not want to be trying to develop these programs on the fly. It's much more difficult. Lastly, I just wanted to talk about the patient perspective from the home patients, and they really, really love telemedicine and these type of modifications. They've been extremely grateful because they feel safer at home, and in many ways they can be as normal as the normal general population that can listen to the social distancing guidelines and the government guidelines to stay at home instead of having to come 3 times a week to the unit. In particular, in New York City, they do not want to ride the New York City subway, public transportation, and things like that, so they were, again, very grateful. Thank you.
Vesh, thank you so very much. The Rogosin Institute has been at the forefront of home dialysis for years, and clearly, I think that served you well in the face of a very difficult situation with COVID right in the heart of New York City. So thank you again. We have been answering questions in an ongoing way through the Q&A function, and we're happy to accept more as they come to us. In the interest of time, we will move on now to the next segment in the the next segments in the symposium. And once again, we are looking forward to writing up with input from all of the speakers today with respect to their various experiences worldwide. And thank you once again to the speakers around the world for our COVID roundtable. All right, so we'll now move on to programs for our latest research in our 3 studies, DOPPS, Pdops, and CKDOPPS. It is about 1/2 so we're down to about an hour and 90 minutes left. What we're going to do is assure that we have made a couple modifications to program, but we'll still ask each of our speakers to limit to a total of 15 minutes, and we'll actually not present one of Dr. Marcelo Lopes presented on hemoglobin trajectories in CKD to the ERA-EDTA, an oral presentation virtually last weekend, and so he won't give that talk here. But as such, we'll be able to still end up on time at the end of on time, finishing up in an hour and a half. So 15 minutes for a total of 6 different talks. Ron Pizzoni is moderating the next session. Ron, any introduction?
Yeah, thanks so much, Bruce. This was such a great session that we just had, and really so informative and so interesting. Yeah, we going along with now to feature some of the studies we've been working on in DOPPS, Pdops, and CKDOPS. We'll move forward with this next part of the session. However, before starting, we just wanted to send kudos out to Hugh Rayner and colleagues who have now come out with their 2nd edition of Understanding Kidney Diseases. It's a really great handbook. Hugh is such a dear friend and great colleague from the UK. Has been a UK country investigator for many years, and has always been so devoted to finding ways of improving care for patients. And as part of that effort, Hugh had written the 1st edition of this book with colleagues a few years ago, and now a 2nd edition. And it's just a really great handbook on clinical practice with over 60 case studies and at least 200 illustrations and so on. And it's just really excellent book for fellows and residents and medical students for understanding key aspects of clinical practice and of kidney disease. So just wanted to say, Hugh, I know we can't hear you right now in the audience, but just fabulous work and continuing to to update this book. And Fritz Port, whom one of our great colleagues in DOPPS also wrote the foreword in this book as well, and with all the great perspectives that Fritz always has. Yeah, so thanks so much. Okay, so then going on to with our hemodialysis study in DOPPS, which is now ongoing since 1996, so we're getting close to the 25th year. And currently in the 7th phase of DOPPS, we have 17 countries participating with about 420 dialysis units right now and just about 12,000 hemodialysis patients enrolled. We've had to decrease enrollment, or enrollment's been somewhat on a pause since the beginning of the COVID pandemic, but the great majority of sites have enrolled many of their patients already, and we expect the numbers to also increase a bit as hopefully the pandemic will be better controlled and so on in the future. But you can see all of the countries listed there. Okay, and so we'll get started with our first talk, which will be given by Dr. Carrie Cavanaugh, who's an associate professor of medicine, is a member of the nephrology and hypertension faculty at Vanderbilt University. And Dr. Cavanaugh is a world expert in studying the very important topic of understanding the many different dimensions of health literacy in the dialysis patient population and how this relates to patient outcomes And we have been collaborating with Carrie on a health literacy NIH-funded project for the last several years, in which has been based on data collected in DOPPS. And so today it's a really great pleasure and honor in welcoming Dr. Kavanaugh to present some findings from this project. So Carrie, thanks so much for your presentation today.
Great, thank you, Ron. Can you hear me?
Yep. Yeah, you sound great.
Okay. Okay. Just wanted to make sure my my office-based phone is voice over internet, so just making sure we're connected. Okay, wonderful. Thank you so much, Ron and Bruce. Thank you so much for inviting me today to share with the DOPPS team overall all the progress we've made to examine health literacy, particularly in hemodialysis. Just with all the conversation about COVID and the transfer of information between ourselves and with patients and caregivers and communities, I think this topic is that much more kind of on par with all the activities that we're doing right now to care for our patients. So next slide, just briefly again, NIH funded as you noted, and I really want to give a shout out and thanks to the DOPPS team overall, and in particular Lisa Henn, who has been our statistician, and my collaborator here at Vanderbilt, Ken Walston. Next slide. So we'll go pretty rapidly through this, but just to get everybody on the same page around the construct and what the topic is, I'll just talk briefly about what is health literacy and its rationale about why we're examining it in hemodialysis. And then I'll go over the data. The DOPPS data is really landmark in that it really is a comprehensive overview of information about prevalence of low and limited health literacy among dialysis patients worldwide. The scope of this has not been done before, and the contributions from this study really advance our understanding. And then we go on to look at associations with patient outcomes among this cohort, as DOPPS does best, and we'll be focusing in on mortality and hospitalizations, access to transplant and listing of transplant, and the use of dialysis access and other outcomes. Next slide. So there are many definitions of health literacy. I propose to you one here that I think really encompasses the elements of the construct. You can think of it as a high-level construct and concept that includes the degree to which individuals can obtain, process, understand, and communicate about health-related information needed to make informed health decisions. And if you look at that little diagram in the lower corner, it's really about aligning, not just characterizing and illustrating and talking about the skills and abilities of patients, but it's about aligning those skills and abilities across the broad population with the demands and complexities of healthcare systems. And you can think of health literacy as the intersection between those two arrows. And the primary requirement really is on us as the healthcare system to change structural processes and systems in ways that make these two arrows aligned in a productive manner. Next slide. And this is just to note that health literacy is on the radar at very high levels. This is the example from the initiative in the United States, but there are similar initiatives, national action plans, funded programs at country level organizations to address health literacy, to understand it, but also more importantly to come up with strategies and actions to ensure that there's improvements in health literacy, not so much at addressing individuals, but addressing organizations, healthcare systems, and what we do within them, such that the two bullets that I highlight there with the arrows are that we're getting all people the right health information that helps them make those informed decisions, and that information and services are delivered in ways that are easy to understand and that improve health, longevity, and quality of life. And what we're doing here within DOPPS is showing evidence that there is a high proportion of people in a need to invest resources and energies into developing, implementing, and disseminating these strategies. Next slide. So I'm not going to spend too much time. It's probably very small on your screens, but there are the slides went away. There's a conceptual model of health literacy, essentially, where it just outlines the inputs that go into the process and the pathways of how health literacy affects outcomes. Okay, yeah, great. And then actually we're just going to focus in on a distilled version of this model. Next slide. Focusing in on the elements that we're examining here in DOPPS and also that are relevant to the, again, the study questions that we've been asking. And so what this model, this distilled model shows us is that what we're hypothesizing is that greater health literacy in general will lead to greater access and engagement in care, and that access and engagement will lead to better health outcomes, including better management of renal replacement therapy, better self-care, ability for a person to be activated and act upon that information, and that those positive outcomes related to improvements in health literacy and engagement will result in greater longevity, less hospitalization, better quality of life. Next slide. So one of the advancements that DOPPS really has contributed in this study is the ability to measure rapidly and validly and accurately health literacy. As we just talked about, you could see health literacy is a pretty broad construct. Many prior work and prior assessments that were developed initially focused on very kind of test-like structural information. And I just show you a snapshot of the gold standards previously in the field for measuring health literacy. And they were more test-like. They asked people to pick out words, to fill in sentences, or to pronounce words. And they operated very well and were related to outcomes very strongly, but they at times introduced feelings of shame and stigma, as well as were more burdensome to administer. So if we go on to slide 89, if we could advance 2 slides. So one of the advancements in the field were the development of screening questions. And these screening questions are asking people to reflect on their own abilities, essentially to engage in care. And there are 3 questions that were developed initially in a VA population. And there were originally 8 questions, but it was distilled down to 3 that were most informative in relating to outcomes and characterizing health literacy. Those are the 3 that in a previous study we collaborated and validated with among hemodialysis patients. We put our publication here that you can look at on your own time. But essentially we showed that these operate similarly in hemodialysis and are important and valid to use as a measurement of health literacy. Next slide. So we already saw this in the introduction. This is the DOPPS map, if you will. And one of the key advancements here in DOPPS is that we are engaging, again, people worldwide and people who are whose primary language is not English. So the majority of the work, especially using those short screening questions, have been in English-based speaking countries. And so what DOPPS has done is gone ahead and localized all of these questions to the different regions, as well as went through the cultural process of cultural adaptation. And then these questions were administered in DOPPS 4 and 5. And so the administration then went out to approximately 11,000 people overall. Next slide. And this again is really tiny, but we will. What you can see here is the translation for some of the questions, and then what you see on the right here is the listing of the countries, highlighting again those that are non-English speaking predominant countries, or again another language, and the function of these questions and their ability to be related to each other to measure the construct of health literacy. And overall, the performance of these questions from a psychometric viewpoint was very strong overall for all the countries except Turkey. So Turkey, we have a little bit more work to do, that the 3 items did not kind of hang together as well as shown in the other countries. Next slide. So this is to give you a benchmark of what is the prevalence of low or limited health literacy. And those terms are used a little bit differently in different studies, but the basic idea is you could think perhaps of around a cutoff of a 9th grade high school education and separating or dichotomizing at that point to those that have lower or limited health literacy to those that have adequate or higher health literacy. And what you see here is a relatively recent summary, systematic review. And you'll notice that most of the studies were quite small, that there was one from the UK that had 3,400 participants, and they used a single item question to characterize health literacy, so just ask one question. So there, again, the information we had prior to the DOPPS information was relatively limited in and of itself. The average prevalence of limited health literacy, again shown by that triangle at the bottom, is somewhere between 20 and 30%, but you can note that there's a lot of variation between these different studies. Next slide. And this is our summary bar chart of what our descriptive findings were here within DOPPS. And what this is oriented towards is separated by a country. So each bar is representing a different country, different region. The counts of patients in those regions are below. And the kind of brighter blue is those that fell into the low health literacy category, measuring 0 to 6 on our scale. And then the orange is the moderate or similar to the limited health literacy, measuring 7 to 10. And the high health literacy, 11 to 12 on our scale, is marked by the dark blue. And again, you see some variation that we see across different countries, different populations, but we're measuring probably a higher prevalence than of limited and low as compared to some of those prior studies that we looked at before. Let's see, we're not, I don't know who's addressing the questions. Okay, and these are the characteristics of the people that were included in our study. We probably don't have time to go through them overall, but what you'll just highlight, what I'll highlight is that there's about an equal distribution, about a third in each category overall, in the low health literacy, moderate, or high, and that the characteristics of patients are similar to what is observed in other studies, in that you'll note that in the low health literacy group, people tend to be a little bit older. We also note that there are some health conditions that are a little bit more prevalent, and we also note that they're more likely to be or less likely rather to be living alone, or to be employed, or to have they're more likely to have lower level of education. On the right, we'll go into some of those outcomes on subsequent slides, so I won't spend more time there, except to note that DOPPS does ask whether people had help with the survey completing it, and you will note that, as we would expect, that people with low health literacy, and again, these are people self-reporting that they're having difficulty engaging with the healthcare system, were much more likely to acknowledge also or have help with the survey. Next slide. Okay, and so this was a prior study, a small study we had done that served as some rationale for pursuing this work, in that we had looked within a small cohort in collaboration with Fresenius within the U.S. as part of their Right Start program, health literacy characterized with the realm, and then looking at mortality over 2 years among incident patients, 480, and demonstrated a relationship between health literacy and mortality, adjusting for some of the measures that we were able to include in that study. Again, it was limited with not substantial adjustment for covariates, and a bit smaller. There were 2 other studies, one by Green et al. In Pittsburgh and then Taylor et al. In the UK, looking at relationships between health literacy and mortality, neither of which were able to identify or observed a relationship in those cohorts between health literacy and mortality. But again, the adjustment variance was different, and again, we have mixed findings. Next slide. So these are our primary results in DOPPS, and again, this is, again, focus on mortality as the outcome. What you have on the left of the slide are the different models for adjustments that we included. The model at base always included adjustment for country, the DOPPS phase that was included, as well as clustering within units. And so that's the base model, and then adding on top of that sequentially, model 1, 2, and 3, add in demographics and other important covariates there, clinical variables or comorbidities after that, and then adequacy and achievement of dialysis measures, if you will. And what you'll see there is that even after adjustment in the final model, those in the low health literacy group compared to the reference group, those in high health literacy, have persistently elevated risk of mortality. Again, in this large cohort, and it's a pretty high point estimate at 1.46. Next slide. We also looked at cardiovascular mortality, a smaller cohort, a little bit smaller number of patients. The point estimates were there, although we did not maintain statistical significance in the later models. Next slide. We looked at hospitalizations. This is the picture there. This is only in DOPPS 5 because we felt it is important to look at hospitalizations after measurement of health literacy. So the size of the cohort was about half that of the mortality analyses. Again, there's maybe some elevation in risk noted among the low health literacy group, but these were not statistically significant in the full model. Next slide. We also, again, looked at access to care. So thinking about health literacy as a concept, really important to think about how people engage with care, transplant, and moving through the process of evaluation for transplant is very important to us. And we also, this is prior data that suggested, again, in a small cohort that by Taylor et al. In the UK, that indeed low health literacy people were at risk for not being listed for transplant. Next slide. We also examined this again in DOPPS. We did, this included about 3,000 patients, 3,500 patients, and this is whether or not at the time of enrollment in DOPPS they were listed for transplant. We limited to those people less than 65, and also in regions where the just transplant listing was of lower prevalence. And we too were able to see within DOPPS that even in the fully adjusted models, and again these models are similar to those that we saw for employed for mortality, that again there was a risk of not being listed for transplant, particularly among those with lower health literacy, but also those with limited or moderate compared to the high health literacy group. Next slide. I think I'll skip this one, although it's just to show that we had those are the different sort of bar charts of the points for each of those, the percentage for each point by country. Next slide. And then we also looked at catheter use, and so permanent access fistula graft versus catheter. And again, that's another aspect of dialysis care that sometimes requires more engagement by the person, both for its care as well as maintenance. And similar to transplant, we did observe that those in the low health literacy group were more likely to be using a catheter. And that was both in and around the time of enrollment as well as within 4 months of the administration of the health literacy measure. And again, the risk was relatively high, even in the fully adjusted model with an odds ratio of 1.5. Next slide. These are kind of tiny, so I apologize for that, but this is just to show that we looked at other self-care behaviors on that pathway, or markers of self-care, if you will, including interdialytic weight gain percentage, serum phosphorus, potassium. None of these were statistically significantly related. There's some nuances related to the sample size and the timing, but the bottom line is, although there were some slight kind of perhaps elevations in some of the point estimates, none of these values or observations were statistically significant in our adjusted models. Next slide. And that was similar to looking at self-reported adherence with medications, as well as looking at whether or not people shortened or skipped treatments. None of these either in our analyses, although we have some information about the point estimate and the variation, but none of these retained statistical significance in the final adjusted model. Some of these sample sizes were smaller than the full cohort looking at mortality and the other outcomes. Next slide. And so the key points of this and some of the major advancements from doing this work is that what we call the brief health literacy screen, or those 3 questions, are valid in hemodialysis across most countries. It's easy to administer and could be considered as part of a screening option to be able to understand if your population or even individuals perhaps need additional strategies or as a population and a unit level, additional strategies could be invested to improve communication, dissemination of information. Health literacy as characterized at the patient level, and the patient reporting themselves is a persistent and strong predictor of mortality in end-stage kidney disease, particularly hemodialysis, and then it's related to other outcomes and intermediary outcomes of importance. More research is ongoing to try to get at those mechanisms, the behavioral mechanisms on the pathway, and other to try to refine those targets. I see in the chat box some of the questions asking about what to do, and there is a whole suite of strategies that can be pursued, and unfortunately we probably don't have time to go over them, but I'm glad to see that this conversation is happening, and I really appreciate the opportunity to talk with you all. Thank you so much.
Carrie, thanks for this really excellent presentation. It's so interesting, and the huge variations across countries and the health literacy patterns that you showed, and then across so many different outcomes that you've looked at here. I'm sure we'll all be looking forward to a paper published on this really excellent work. In order to unfortunately, with the time being as it is and the remaining talk for today, we just encourage folks to submit questions via the chat box. Then we're asking each speaker after their presentation if they could take a look at that chat box and try to respond to those questions. But Carrie, again, thanks so much for such an excellent presentation.
And Ron,
thank you so much.
Yeah, just to note, those responses should be viewable by all in the audience as well. So thanks. Actually, Carrie, you've got a list of 5 questions or so. So thank you.
Okay. All right. Thanks, everybody.
Okay, so we will then go on to our next presentation, which will be given by Dr. Masahiro Iraguchi, who's an assistant professor in the Department of Nephrology at Nara University. And today, Dr. Iraguchi will be presenting a very interesting and quite unique topic in describing and relating levels of 2 key cardiac biomarkers with outcomes as measured routinely in a cohort of Japan DOPPS hemodialysis patients. And it's a real pleasure to have this presentation by Dr. Iraguchi today. And I just want to say also, Bruce and I had an opportunity to visit Nara a few years back, and what a beautiful city it is, and with a really incredible Tadaiji temple, which I believe was built when Nara was served as the capital of Japan in the 700s. But so Dr. Iraguchi, thank you so much for giving this presentation today.
Okay, can you hear me?
Yes, you sound crystal clear.
Okay.
And I also want to say it's very late in Japan too. Please go ahead.
Okay. Okay. Thank you. I'm going to talk about the routinely measured cardiac troponin I and NT-proBNP as predictor of mortality in Japanese HD patients. Next slide, please. The cardiac biomarker, including cardiac troponin and neutral-weighted peptide, are strongly predictive of heart failure in the general population. Although HD patients had highest risk for CV death, international DOPPS data indicated that these cardiac biomarkers are measured in fewer than 2% of HD patients in real-world practice. The benefit of routine measurement of these cardiac biomarkers are not confirmed in the asymptomatic HD patients at this moment. This study aims to examine whether routinely measured NT-proBNP and cardiac troponin I can be helpful for classifying risk of HD patients. Next slide, please. This is National Prospective Cohort Study. 1176 prevalent HD patients enrolled in JDOPPS phase 5 were prospectively followed up for 3 years. Predictors are cardiac troponin I and NT-proBNP at baseline. Primary outcome is all-cause mortality, and secondary is incidence of MACE. Cox proportional hazard models were used to evaluate the association between cardiac biomarkers level and outcomes by adjustment with potential confounders. Stratified analysis were also performed using possible effect modifiers. Next slide, please. Cardiac troponins are expressed selectively in the heart. Therefore, cardiac troponins are regarded as cardiac injury markers. Specifically, a diagnostic treatment guide for patients with suspected acute coronary syndrome. Cardiac troponin I levels are measured by contemporary assay, which is not high sensitivity assay, but clinically relevant sensitive assay. The definition of high sensitivity assay is percent coefficient of variation, CV, at the 99th percentile should be less than 10%, and the proportion of unmeasurable person must be less than 50% among the general population. This assay is sensitive enough to evaluate the participants in this study. 10% CV concentration is 0.03 nanogram per ml, which is less than 99th percentile of this assay, and only 20 to 30 participants were unmeasurable. About 29% were above the 99th percentile, which is generally used as cutoff for ACS in general population. Next slide, please. Nucleolytic peptides are released by cardiac wall stretch in response to pressure stress and volume overload. Therefore, BNP and its inert metabolite NT-proBNP are gold standard marker for heart failure. In the setting of chronic heart failure, diagnostic cutoff for NT-proBNP at 125 picogram per ml are recommended to rule out the presence of chronic heart failure in the clinical guidelines. Using this cutoff, almost 100% of patients had elevated NT-proBNP levels. The median of 3,432 picogram per ml, which is extremely higher than general population. Next, please. Here is the association between cardiac troponin I and NT-proBNP, up to 0.04 nanogram per ml, which is 99th percentile in healthy subjects. NT-proBNP and cardiac troponin I had weak positive correlation. Interestingly, some patients with unmeasurable level of cardiac troponin I had extremely high levels of NT-proBNP and vice versa, suggesting these two cardiac biomarkers may reflect different aspects of abnormalities. Next slide, please. Here is the baseline characteristics stratified with each cardiac biomarker. Patients with higher levels of both cardiac biomarkers were likely to be older, have more CVD, had lower serum albumin and hemoglobin level, and higher use of antihypertensive drugs. Next, please. Different from cardiac troponin I, higher levels of NT-proBNP were associated with longer HD vintage and lower serum phosphate level. Next, please. This is the association of cardiac biomarker with mortality. Among 1176 patients, there were 175 deaths during median follow-up of 2.8 years. In the main model, the association of the third or higher category of cardiac biomarkers with mortality was statistically significant. Of note, even after adjustment for alternative cardiac biomarker, in addition to the main model, these associations remained significant, suggesting that, again, these two cardiac biomarkers may reflect different pathologic aspects. Next, please. Okay. Okay, thank you. Okay. This is the association of cardiac biomarkers with MACE. Among 1165 patients, there were 174 MACEs. Similar associations were observed between both cardiac biomarkers with MACE in the fully adjusted model. Next, please. Okay, here is the subgroup analysis. Heart failure, coronary artery syndrome, and age did not modify the association of both cardiac biomarkers with mortality. Each p-value for interaction for more than 0.10. Next, please. There was not statistically significant association of both cardiac biomarkers with mortality among patients with heart failure. Therefore, we speculated the association would be modified by the presence of heart failure. We performed further analysis. Next, please. We divided into 6 subgroups according to presence or absence of heart failure and 3 categories of biomarkers. As you can see, similar hazard ratios are observed between with or without heart failure in each category of cardiac biomarkers. Next, please. Hi. There were 3 studies examining cardiac biomarkers among HD patients and non-HD CKD patients. Cardiac troponin levels were very high in CLIC study compared to the others. On the other hand, NT-proBNP levels in HD patients were extremely higher than non-HD CKD patients. Also, mortality and incidence of MACE in choice study are much higher than the other studies. So, despite the fact that the prevalence of elevated cardiac biomarkers level and the incidence of mortality or MACE were extremely different among the study population, the prognostic importance of significance of these cardiac biomarkers were reported to be very consistent, meaning these cardiac biomarkers had consistent prognostic power in any population group, but each population group had different cutoff points. Next, please. Here is conclusion. They routinely measure the NT-proBNP and troponin I are strongly associated with mortality with among the prevalent HD patients. These associations were still significant even after adjustment for alternative biomarkers, suggesting these cardiac troponin I and NT-proBNP may reflect different pathologic aspects of cardiac abnormalities. Routine measurement of these cardiac biomarkers in HD patients with or without a history of heart failure may help identify the patient at risk of death who may have undetected subcritical cardiac damages. Thank you.
Dr. Araguchi, thanks so much for giving such an interesting and really very important study, particularly in seeing these elevated cardiac biomarker levels in patients without pre-existing heart failure. And it really raises the questions of, how much undetected cardiac damage, patients with cardiac abnormalities exists, and it certainly raises a question of more routine use of testing for these biomarkers in assessing risk for your patients. I'm sorry that we're not able to ask more questions, as I'm sure that many audience members would have really like to discuss this a lot. But please look at the chat box and try to respond to questions there. In view of our time right now, we've decided not to give the presentation that would have been led by Dr. Angelo Caraboyas from Arbor Research, which would have described ETAL calcitide use and how it relates to MBD control in the United States. It's a really very interesting study, and one we're just about soon expect to submit for publication in this month of June. And we did have a poster on it at ASN with some more work since then. So then, in view of the time, we'll then go on to our Pdops session, which was going to be moderated by Dr. Jeff Pearl from the University of Toronto, but in view of our having moved this by a week, Jeff had clinical duties this morning and was not able to attend, so I'm stepping in reserve for Jeff. And then going on to the next slide, currently we have 6 countries participating in Pdops, as can be seen here: Canada, the U.S., the UK, Thailand, South Korea, and Japan, and about 230 PD units, and data accumulated thus far for about 11,000 PD patients. In phase 1, we also, Australia and New Zealand were participating as well. And so then we'll go on to, we have 2 presentations this morning, and the first one will be given by Dr. Muthana El-Salawi, and it's been a great, from King Faisal University in Saudi Arabia. It's been a great pleasure working with Dr. El-Salawi during these past 2 years through our OPUS project, which is to optimize prevention of PD-related peritonitis. And Muthana, and working closely with Jeff and our OPUS team, actually led our first paper in OPUS, which was a systematic review of the reporting of PD-associated peritonitis outcomes in clinical trials and observational studies. It's been so impressive working with Dr. El-Salawi, and we should thank him so very much for his great contributions to our OPUS project and in giving his presentation today. Muthana, thank you so much for giving this talk.
Thanks, Tom. Can you hear me?
Yes, yep, can hear you very well.
Perfect.
Yeah, please.
Perfect. Thank you so much for having me. It's a real pleasure to be here today to share an update on the Pdops study that we've been working on, looking at variation in PD versus peritonitis outcomes and treatment practices across the countries participating in the Pdops. So PD peritonitis is actually a very concerning complication of peritoneal dialysis and be associated with substantial morbidity, mortality, more treatment costs, and hospitalization events. And despite the advances in PD connectology and preventive strategies, peritonitis actually remains the leading cause of kidney failure and the transition to hemodialysis across the majority of the countries worldwide. The overall peritonitis treatment failure rate can be as high as 25%. And for that reason, a contemporary evaluation of peritonitis characteristics and treatment strategies that can actually maximize the likelihood of a cure and also reduce the peritonitis-related adverse effects is needed. Next slide, please. So you can see in this chart bar, among the Pdops countries, PD-related infection is the most frequent cause of technique failure and hemodialysis transfer. Although it varies by country, but it remains the most common cause of hemodialysis transfer in all of the countries. Next slide, please. Next, please. Previous reports have actually looked at peritonitis outcomes across national registries. For example, Brown and colleagues reported outcomes of around 2,000 episodes in Scotland. Galleries used also the AIMS data to report outcomes of 6,000 peritonitis episodes between 2003 and 2008. And also Mulgate report peritonitis outcomes in 35 units in the US and 26 units in Canada. And as you can see here, the percentage of episodes that were resulted in a cure were ranging between 75 to 80% in both countries. Next slide, please. So the big question is how to reduce peritonitis-related patient loss. So we can do that by either reducing peritonitis incidence by improving the preventive strategies, or by reducing the loss rate once peritonitis has occurred. In order to do that, we need to identify characteristics and management practices that can maximize the cure. So next slide, please. So our objectives were to describe regional differences in peritonitis cure rates across countries enrolled in the Pdops, and also to explore the impact of various patient treatment and peritonitis characteristics on the likelihood of the cure for peritonitis episodes, and also on the individual peritonitis-related adverse events, including death, PD catheter removal, transfer to hemodialysis, and relapse with peritonitis. Cure actually here in our study was defined by the absence of these events, the adverse events, within 50 days of the onset of peritonitis episode. Next, please. So we used the Pdops phase 1 data from 2014 to 2017 from 7 countries, including Australia, New Zealand, Canada, Japan, Thailand, United Kingdom, and the States. Patients 18 years old or more were included from certified random national sample of PD facilities that treat at least 20 patients at time of selection. We have excluded hybrid patients, those who are on PD plus hemodialysis, and those were primarily in Japan. Our outcomes were cured, which is the absence of adverse events, including death, HD transfer, catheter removal, recurrent or relapsing peritonitis. Association between the country, the organism, and the treatment characteristic and the likelihood of a cure were assessed using multivariable logistic regression. Next slide, please. So this figure shows the odds ratio of peritonitis cured by country, with the United States being the reference group. So we had 1,677 peritonitis episodes among 1,190 patients in 126 facilities. Overall, peritonitis cure was achieved in 63% of episodes, ranging between 64 and 68 in Japan, Canada, United States, and Australia and New Zealand, and was 57% of episodes in the UK and 54 in Ireland. And after we adjusted for different variables, the between country differences in terms of cure were not statistically significant. Next slide. Okay, so this chart bar shows the adverse outcomes by country. So cure was not statistically significantly different between countries. Mortality was as high as 50% in Thailand compared to only 2% in Japan. We'll discuss later the possible explanation of that. In terms of the remaining of the countries, mortality range between 4 to 6%. We also observed high rates of transfer to hemodialysis following peritonitis episodes in almost all countries, ranging between 15 and 19%. Next slide, please. We also looked at the cure by organism type. So we demonstrated lower cure for gram-negative peritonitis, polymicrobial, and fungal, and compared to gram-positive peritonitis. Culture negative, on the other hand, was not associated with lower significant odds of a cure, but there was a trend. That was not significant. Okay, next slide, please. Next. Yes, thank you. So, cure by organism. So, with the start aureus as the reference group, fungal peritonitis was antibiotically associated with the lowest cure, followed by the pneumonal infection. And this is actually consistent with the previous study showing that the pneumonal are usually associated with higher rates of adverse events, including hospitalization, exit site and tunnel infection, catheter removal, and HDE transfers. And perhaps this is why the ISBD guidelines is meant to use 2 antibiotics when treating the pneumonal infection. Next slide. So we were able to identify some characteristics and practices that are associated with higher likelihood of cure. So patients with previous slide. So patients with PD had higher odds of a cure. Patients with higher serum albumin also had higher odds of a cure. We also look at the icodextrin used, and we found that centers using icodextrin were having higher odds of a cure compared to those who don't. Next slide. One interesting finding that we observed in this study is the significant higher odds of a gram-negative peritonitis cure with aminoglycoside compared to cytazidine. Now, the ICD suggests using either of those antibiotics for gram-negative coverage. However, this finding is very interesting, especially it's very important in centers where there's a high incidence of cephalosporin-resistant organisms such as ESBL. And this is something that may warrant further consideration of ICD guidelines in terms of peritonitis treatment protocols. Please. In terms of adverse events, this slide showed the adverse events associated with characteristics. So we demonstrated higher odds of this in patients with lower serum albumin and increased age, and this is actually consistent with the previous study. One important observation is that there was higher rates of peritonitis relapse in patients with more residual kidney function. This actually may be related to the higher antibiotic clearance by patients with more residual urine volume, which can result in subtherapeutic blood levels. Moreover, we observed higher catheter removal and hemodialysis transfer in patients with concomitant exit site infection. And this is expected as refractory exit site infection is usually an indication to remove the catheter. Next slide, please. So although this was the largest international study looking at variation in peritonitis outcomes and management practices, we do have several limitations. So first is the observational nature of the data and the possibility of center bias, because the included facilities may be actually different to other centers within the same country in regard to TB practices. Also, the limited number of the facilities, the missing data, and the heterogeneity in a facility and also across facilities within the same country may make it difficult to draw a definite conclusion about the differences between countries. And lastly, our sample was nearly consistent of high-income countries. So our results may not be generalizable to countries with low income and resources. Next slide, please. So what are the take-home messages and the conclusion? Although the cure rates was not different between countries, but we observed significant variation in other adverse events, including mortality. So mortality was 50% in Taiwan compared to 2% in Japan. The low mortality in Japan may be related to the careful patient selection for TB, as TB only accounts for 2.8% of dialysis modality among patients in the stage renal disease in Japan. On the other hand, is a TB-first country, so there might be more less healthy and more comorbid patients in this country receiving TB. Also, we observe higher rates of techniques and hemodialysis fracture in all countries, ranging between 16 to 19%, and this is actually unacceptably high, and suggests that we need better and more intervention to prevent and treat peritonitis. And also, at the same point, we also need more intervention. The peritonitis outcomes can vary by the causative organism, especially that we showed that fungal peritonitis and pseudomonas are significantly worse than other organisms. This actually suggests that we need more tailored and effective treatments that are organism specific. So finally, so what clinics should consider in terms of management practices? First of all, and more importantly, aminoglycoside might actually be better antibiotic for umbilical gram-negative coverage compared to Fatality, particularly as I mentioned in clinic with high cephalosporin-assisted organisms such as ESPO. Another point is the observation of more peritonitis relapse in patients with residual kidney function. And this finding may suggest that we need to dose the antibiotic on the basis of the degree of residual kidney function. Also, we need to understand why APB was associated with higher odds of a cure than CAPB. It might be related to patient characteristics, might be like more healthier patients are doing APB. Finally, we also and finally, something to consider is the antibiotic for the exit site. Aminoglycoside might be better compared to mobile-routine in preventing duodenal infection. So in the clinics with high incidence of the infection, they might be considered using amino glycoside-based cream over mobile-routine. Now, I understand that some nephrologists and PD units might have concern about the nephrotoxicity that might associate with amino glycoside in patients who have residual kidney function. But actually, previous observational studies showed that when you use short-term amino glycoside courses for 2 to 3 weeks, that was not associated with decline in residual kidney function. And I guess that's all for me. Thanks so much for the opportunity to speak today, and I'll be happy to answer the questions in the chat box.
Thank you so much, Mathana. Such a great presentation and so much information there that I think will be really helpful for improving practices related to peritonitis prevention in the future and covering so many different aspects of care. So yeah, thank you so very much. So we'll then move on to our final presentation in this Pdops session. And it's a real delight and honor and pleasure to have Professor Edwina Brown giving this next presentation. Professor Brown is a consultant nephrologist at Imperial College Renal and Transplant Center at Hammersmith in London. And Professor Brown's main clinical and educational interests have been in peritoneal dialysis, and particularly dialysis in the elderly, renal supportive care, and cognitive impairment in CKD, and how these impact patient outcomes. Professor Brown is also the chair of the Guidelines Committee for the International Society of Peritoneal Dialysis. And so Edwina will be presenting today on a investigation she has led in DOPPS, comparing health-related quality of life and dialysis burden in PD compared to in-center hemodialysis patients. And Professor Brown, thank you so much for all your efforts in leading that study and for this presentation today. Thank you.
Well, thank you. And thank you for the invitation to present at this meeting. Have the next slide, please. So the study has now been completed. We submitted it to Jason. It's just been rejected by Jason, but we will be sending elsewhere. We've called it the Burden of Dialysis, Health-Related Quality of Life and Employment Comparisons between PD and in-center hemodialysis. And I'm very grateful to all the authors of the study, and particularly all the stats that have been done by the DOPPS program to enable this really interesting study to take place. Next slide, please. So the background is that most comparisons of quality of life on hemodialysis and peritoneal dialysis are cross-sectional, small numbers, and there's very little longitudinal data. But people need this information when making decisions about choosing whether they want hemodialysis or peritoneal dialysis as their dialysis modality. Furthermore, longitudinal studies are even fewer than the cross-sectional studies. And having conducted one myself, I'm not surprised. They're difficult to do, and they're very difficult to interpret. People die, they get transplanted, they become too sick, or they just get bored with filling in questionnaires. So there's a huge drop-off between the baseline data and the subsequent data. Next slide, please. And this is shown very well in this slide. This is the largest prospective longitudinal study that's been done. It comes from South Korea. I don't want to focus too much on the top bit of the graph, but it basically shows very little small changes that take place over time in different components of quality of life, but really focus on the numbers in the bottom half of the slide, and that shows that of 650, 300 hemo, 330 PD patients who were studied at baseline at 3 months, by 12 months, numbers have dropped by 50%, and by 24 months, they were down to 150 hemo and 112 PD. Next slide, please. So the aims of the study were to use the quality of life data that is accumulated in both the DOPPS and the Pdops studies. And the information collected has been on quality of life, but also employment and functional status. And to use this data to understand both cross-sectional and longitudinal changes in quality of life in patients on dialysis, and understand whether dialysis modality impacts on this, and what are the differences between different countries. Next slide, please. So the patient sample was from the Pdops, both phase 1 and phase 2, and from hemodialysis, DOPPS 5. So patients with prior transplant, PD patients with prior hemo, and hemo with prior PD were all excluded, and only countries where both Pdops and DOPPS centers existed were included. So the primary outcomes were from the KD-QOL, the physical and mental component scores, and the burden of kidney disease score. We also looked at functional status, being employed, and depression, and changes in outcomes were based on people who had completed 2 consecutive patient questionnaires, and that was approximately 1 year apart between the 2 sets of questionnaires. Next slide. Patients unlikely to be eligible for PD were excluded, and this was based on demographics, comorbidities, and countries. Baseline data, logistic regression was used when there was binary outcomes, such as with the CESD for depression, or functional score greater or less than 11, and for linear mixed models were used to analyze the continuous outcomes, such as in the burden score, the PCS, and MCS from the KD-QOL. And all of these were adjusted for country, demographics, comorbidities, and transplant waiting list status. Longitudinal analyses for the categorical outcomes it was calculated percentage of patients whose responses stayed the same or changed, and continuous outcomes were calculated differences in outcomes. Next slide, please. So this figure shows the number of patients who were enrolled at the start and who persevered to the 12-month follow-up. So there were over 3,000 PD patients, 4,500 hemo patients with the patient questionnaire data. When you've excluded patients who are unlikely to be on the other dialysis modality, that left us with 2,664 patients on PD and 3,132 on hemodialysis. And then at the follow-up of the 12 months, having excluded those who died, those who dropped out of the study, or those who didn't complete the questionnaires, numbers have dropped down to 880 on PD and 1,338 on hemodialysis. Next slide. So this shows the basic demographics by PD and hemo in the baseline group of patients. And you can see that really these were very similar in terms of age, terms of gender, and also years on with end-stage kidney disease. Body mass index was very similar. Diabetes was very similar. The big difference was in the transplant wait list, but that may well be partially due to the high number of hemo patients in Japan. Next slide, please. The most striking findings, which I really want to emphasize, was the burden of kidney disease score. So this is the initial data by country. So at the top of the bars is the lower burden of kidney disease, and in the bottom is the higher burden of kidney disease. The column on the left is hemodialysis, the column on the right is peritoneal dialysis for each country. And you can see that in all countries there was more, the proportion of people with the lower burden of kidney disease score was highest in PD, and the proportion of people with a high burden of kidney disease score was lowest in PD. Next slide, please. So when these are all adjusted, again, the burden of kidney disease score is lower in the PD, so to the left of the bar of the central line is always better for PD, and the most striking observation is the better burden of kidney disease score for PD compared to hemo. The scores were similarly better for the mental component score and the physical component score, but much smaller. And this was true across all countries, whether people had diabetes or not, across genders, whether they had a fistula graft or a catheter, across different age groups and different vintages of dialysis. Next slide. For the binary patient outcomes, again, these were mostly better for PD compared to hemo. So this is true for employment, mostly true for the depression scores, and true for functional status. Again, across all different groups of the patient studies. Next slide. Looking at the longitudinal aspect of this study, this shows the changes over 1 year in the mental component score, physical component score, and burden of kidney disease score. And what is striking is the similarity. There's really no change in either hemo or PD over the 12-month period. Next slide. And similarly, in functional status, the binary scores, you can see that most people remain in the same group. So there's very little movement from on the left, the worst functional status, and on the right of the graph, the better functional status remains very stable over the 12-month period. Next slide. So in summary, the burden of kidney disease scores are better in PD in all countries. In all countries, patients on PD had a higher functional status scores, were more likely to be employed, and had lower or better depression scores. Models adjusted for country demographics and comorbidities, the patient-reported outcomes were generally better for PD. There's a strong association between PD and better burden of kidney disease scores, and this was consistent across all subgroups. And longitudinal changes over time were small and for both categorical and continuous measures. So similar at the end of the follow-up compared to the beginning. Next slide. There are obvious limitations to this study. The DOPPS and the Pdops data were collected over different time periods. The countries were restricted to those enrolling centers in both studies. Patients are going to be healthier than average as they have to consent to take part in the study. And as with other longitudinal studies, there's a significant dropout of patients between baseline and subsequent measurements. Last slide. Next slide, please. So in conclusion, this is the largest single study comparing outcome measures in patients on PD and hemo. The most striking finding is consistently the lower burden of kidney disease scores reported by patients on PD. Patients on PD reported mostly better quality of life, higher functional status, and were more likely to be employed. The principal observation from longitudinal analyses was the stability of outcome measures over time for both hemo and PD patients. And really this information, particularly that about the lower burden of kidney disease on PD, is important for people when making modality choices, and it's also important for development of national policies affecting dialysis modality availability. Thank you.
Edwina, thank you so much for such an interesting presentation. And as you say, this will be so informative for patients and policymakers as well. And it's just so helpful to have this kind of information. And so we look forward to the paper being published in the near future. So, Roberto, would you like to speak then regarding the CKDOPS part of this presentation, though I realize we probably only have 9 minutes left in our session yet today.
That's right, Ron. And so we've been discussing here, and what do we do? We'll just very briefly update everybody on the current status of the project, and then we're going to just say a few words about the 3 projects that we selected to present today. So may I have the first slide, please? The CKDOPS currently is ongoing in 5 different countries, the U.S., Brazil, France, Germany, and Japan. And as you can see here, the numbers would add up to a total of about 11,000 patients being followed in those different countries.
FSCEHRY.
So in the CKDOPS session today, we plan to present 3 papers, and they are listed here. The first one is actually a study that we are very excited about. It's an important study for the future of the kidney failure outcomes in CKDOPS. And Jersey Z, who is a research scientist here at Arbor Research, is leading their work. She's actually sitting across the table from me today, and I'll just let her very briefly describe about what this project is all about. Jersey?
Great, thank you, Roberto. So as Roberto said, this is a project that, so it's a kind of methodological project to look at CKD progression surrogates for kidney failure. As those who follow the CKD literature know that there's been a lot of discussion over the years about endpoints for CKD. There's also been recent consensus conferences talking about nomenclature as well as definitions for kidney failure. And so in CKDOPS, which as you all may know is a unique cohort of advanced CKD patients from several different countries, we wanted to evaluate some of the different CKD progression endpoints in their ability to capture kidney failure. So these include definitions like dialysis or transplant for kidney replacement therapy, as well as laboratory-based endpoints such as sustained eGFR less than some cut point or a percentage decline in eGFR, as well as composites that combine some of those laboratory-based measurements with kidney replacement therapy. And so in this project, we really wanted to compare these potential surrogate endpoints for accuracy and power
to capture kidney failure among this international advanced CKD patient sample. And just to give you a preview, we did find that our composite outcomes did give us more power, and those that included the sustained eGFR less than some threshold in this sample still gave us pretty good predictive discrimination. So I'm sorry I couldn't share more of the details with you today, but we did submit this for an ASN abstract, and so we'll be sure to let you know if that's accepted.
Thanks very much, Darcy. And the reason for us to really going through this very briefly is because we do have a hard stop at 11 o'clock because the system would just shut down at that time. And I still wanted to have Bruce say a few words about this just to wrap up the session. The second project that we were going to present to you today is a combination of two presentations at ERDTA. So Marcelo Lopes and Murilo Guedes, both from Brazil, actually presented this last week in the ERDTA. The first one, the first presentation was by Marcelo, and he actually had an oral presentation at ERDTA. So for those registered in the Congress, I believe that the presentation is available until July. So please go there and check out the presentation, which is really a very interesting work looking at longitudinal practice patterns and really highlights the massive undertreatment of anemia in non-dialysis CKD. And finally, the last presentation was going to be given by Mathilde, who is a PhD candidate working with Christian Combe in France, and she also had an oral presentation at ERDTA, so available there, the website of the Congress, and that's on uric acid and chronic kidney disease progression of mortality. This work is actually based on the CKD RAN cohort. So with that, I'll just pass the mic back to Bruce for some final remarks. Bruce.
Roberto, thank you very much. Thanks to everybody once again for listening in today, and to our numerous speakers for your presentations, literally from around the globe, and for our indeed successfully finishing on time with a couple modifications and adjustments. And we appreciate all the comments and questions, which all have been answered as well through the Q&A function. I would just note again, with the DOPPS program, it's incredible that this is our 25th year up and running, and it's just been a great honor to work with everybody, and to continue to think about ways that we can contribute and make a difference, and innovate, so that we're continuing to be right front and center to what's important ultimately, to do what we can to help patients. So really listen to patients and really help them out. And with the DOPPS, our goal is, of course, to help disseminate most useful information to practitioners worldwide. I would highlight again a couple areas of real importance to us. Number one, again, we have 3 studies now that are up and running and very robust, active around the globe. Our ancillary study program has been very active. We continue to look for folks interested in seeking ancillary funding to work with the DOPPS program data, and folks who come in with particular specific research projects. This really strengthens the product that we all can provide to the community. So secondly, once again, focus on providing opportunities for younger investigators is just so critically important to us. And again, we had numerous examples today of this, but there remains more to do. So again, happy to hear from any folks about ways to continue to extend our resources to younger investigators. Newer countries we're always very interested in, particularly those in sort of the middle income country space. We look at Brazil, Thailand, just as a couple examples of studies that launched relatively recently. And we really feel we can help out in countries such as those. So again, this is an area of real focus for us. Specific to COVID, I think the name of the game is from our standpoint, is to help get the word out and to do it quickly. This is such a rapidly evolving field, so we do look to write up the work that was presented today by colleagues worldwide. As noted, we have a quantitative survey that's out to our sites, and we do look to look at those data quickly and publish on those and act upon those, and really and additionally compare home dialysis versus in-center dialysis in that regard. We're also looking to extend the reach of that survey through a partnership with the ISN. So really very, very exciting. With that said, we're right at the top of the hour. So we'll do this again, and we'll do it at the time of ASN as per typical. Most of you have just heard, I'm sure, that the ASN has decided to be entirely virtual this year as well. So we will follow that guidance and schedule a virtual autumn update meeting just before the ASN at the end of October. With that, thank you all once again, and hope you all have a wonderful weekend. Bye-bye.